Good afternoon. Today I want to share 3 chapters in my childhood, each time when I thought I was going to die. Abdominal trauma, measles, aspirin overdose, and what they taught me about learning ultrasound, teaching ultrasound, and what ultrasound can now teach us. Chapter 1. When I was 15, I learned 2 things about abdominal trauma. Number 1, wear your seatbelt. And number 2, never phantom scan. So it was 1985. I was 15, too young to drive. My friend and I went to the movies. Her father picked us up, and we were within 1 mile of their home, 1.6 kilometers. And we know that's when most accidents happen. That's when we were in a head-on collision with a drunk driver. Talk about an emergency physician in the making. And I thought I was going to die. I remember the car coming towards us very, very fast and in our lane. It was like being at the amusement park in a bumper car, except this was real. It was much louder, and there was much more impact. I was actually thrown to the floor of the car. In the emergency department, the doctor did a fast exam. He said it was negative. He said it was normal. I went to get copies of those images, and there were no images. I got a copy of the chart, and there was nothing in there about an ultrasound examination. But I remember the cold gel, and I remember a probe being placed in 4 areas. Now, when I talk about phantom scanning, I realize some of you may not know what I'm talking about. A phantom scan is a quick look scan. It's the roll the machine to the bedside or carry it to the bedside and just do a quick look. Just reassure yourself, answer a question. No labeling, no saving, no archiving, not writing a note in the chart, no send for quality review. Now, the reality is, it was 1985. There were no seatbelt laws. It was merely a suggestion. And ultrasound had by no means hit the mainstream of emergency medicine. So I didn't have a fast exam. There was no ultrasound. But that's the thing about phantom scanning. We just don't know, do we? Would you ever perform a lumbar puncture and not write a procedure note? Would you ever intubate a patient and not describe the pre, mid, and post-procedure? Then why would you ever do this with ultrasound? Maybe you're not really confident about your image acquisition. You think they're bad. But we know bad becomes good, good becomes better. Maybe you're not really confident about your image interpretation. Maybe you're worried about medical legal ramifications. Well, there's actually literature. One looked at malpractice cases in the United States, emergency physicians, ultrasound over a period from 2008 to 2012. There were 5 cases. Each was related to a failure to perform ultrasound or a failure to perform it in a timely manner. None were related to misdiagnosis. Now, whenever I get in a car, I always put on a seatbelt. When you do an ultrasound, please don't phantom scan. Label it, save it, archive it, write a note. It's safer for your patient, it's safer for you, it's better care. Chapter 2. Going back years, when I was 9, I learned 2 things about measles. Number 1, vaccines work. And number 2, measles is probably here to stay. Ultrasound is too. And in fact, ultrasound's kind of gone viral. Good viral. We were going to visit family in Alabama, and my mom had read that there was a measles epidemic ongoing. She is by no means an anti-vaxxer, and in fact, she called the pediatrician and insisted that we get a booster immunization. Now, simultaneously, I was taking ampicillin, and I don't know if you remember from the 1970s, it was that cold, thick, strawberry-flavored liquid, ampicillin, that it seemed like I was on for all of the decade of the 1970s because of strep throat. It was our last day in Alabama, and I was running around playing with my cousins. My mom said, "Risa, come here." She looked at my face. She said, "You have a rash all over your face." Then she picked up my shirt, and it was all over my body. Gravely, she said, "You have the measles." Now, I thought to myself, "Risa, you pride yourself on being so observant. How could you have missed this full-body rash?" And number two, I feel fine. How can I feel fine and have the measles? And number three, I think I'm going to die. I don't know anybody that has the measles. And I don't think you live when you have the measles. The whole way back on the airplane, I couldn't sleep. My mom would look over me kind of worriedly, kind of accusingly, as if I had done something wrong. And it wasn't lost on me that if I really had the measles, wasn't I exposing everybody in the airport and everybody on the airplane? Now let's think about vaccines for a second. In general, it's a live attenuated virus to which we're exposed. Our body produces antibodies, and we're able to fight the disease. So think about ultrasound as the virus. And thinking about learning ultrasound, becoming competent in ultrasound as a way of vaccinating yourself. And surrounding yourself by people that know ultrasound and utilize ultrasound does not make you immune. Now, everywhere I've worked, New York City, Denver, now Philadelphia, the boss always wants me to create a faculty credentialing plan. So that's like a training for the consultants who never learned ultrasound, to get them up to speed, to make them use ultrasound. And it's been a nightmare. We've studied it, we've surveyed it, we've created committees on it. People end up resenting what they perceive as extra work. They resent you telling them how to provide patient care and change their practice. They resent feeling awkward and insecure and having to be vulnerable in front of you with the machine holding the probe, getting the images, and ultimately they just end up resenting you. From what I've seen, you can't make someone get vaccinated, and similarly, you can't make someone learn ultrasound. No matter how user-friendly, unintimidating, really organized your plan is. I think it takes that one case, that one save, or that one procedure that you do blindly that has a bad outcome. Whether it's a pregnant patient, vaginal bleeding, you put the probe in the right upper quadrant, you see fluid, ruptured ectopic pregnancy, straight to the operating theater. Or the elderly patient with hypertension, you have that one reading of hypotension, and they had pre-hospital syncope. Put the probe on the abdomen, pulsatile aorta, leaking AAA. Or maybe the central venous line that you place blindly, pulsatile bright red blood. The next morning in Rhode Island, all the lesions on my face had gone away, and I had many fewer on my body. I went to the pediatrician's office. The nurse took one look at me. "You don't have the measles." I didn't have the measles. What I probably had was a post-Epstein-Barr virus ampicillin sensitivity reaction, but of course I had to wait till medical school to learn that. Measles is here to stay. Ultrasound is too. Let's figure out ways to train and learn ultrasound without a forced program that really doesn't work. Chapter 3, going back even more years. I was 4 years old. I learned two things about aspirin overdoses. Number one, an empty pill bottle is a toxic number of pills ingested until proven otherwise. Number two, human error is inevitable. So with machine learning and intelligent machines, perhaps we can make some of these errors less common and minimize the risk. So as I said, I was 4, and my brother was in school. I was not yet in school, but of course I felt I was old enough to be. And it was a weekday afternoon. My mom was taking a nap on the couch, watching television. There were soap operas on, and there was definitely a commercial of a woman that had a splitting headache, and she needed an aspirin with her headache. Now, this was before the time and the scare of Reye's syndrome, so they gave us aspirin. I had had the St. Joseph's baby aspirin, that horrible kind of orange-flavored pills. And I became convinced that I had a headache and I needed an aspirin. So I told my mom, I said, Mom, I have a headache, I need an aspirin. She said, Risa, no aspirin. Like, Mom, I really, really, really need an aspirin. And we just went back and forth, back and forth. Finally, she relented. She said, okay, Risa, one tablet. I said, okay. I ran upstairs, jumped on the bathroom sink, opened up the medicine cabinet. There were 3 tablets. Now, she said 1. I knew the dosage was 2. In my practical little mind, it would be wasteful to not just take 3. So I took 3 tablets, threw away the bottle. Dinner time came, we ate dinner. At some point, my mom discovered this empty pill bottle. Not knowing how many were in there, she thought that I ingested the full bottle. Side note, I was not tachypnic. I was acting normally, no nausea, vomiting, and I was not complaining of ringing in my ears. Nonetheless, my parents decided that they needed to induce vomiting. Now, you could argue that I made an error in judgment in taking those 3. And similarly, you could argue that my mom and my dad made an error in thinking that I had ingested the full bottle. But these mistakes and these errors are going to happen. Luckily, we have artificial intelligence to help us with some of these decisions. Now, artificial intelligence technology with ultrasound has arrived. It can actually help with image acquisition, interpretation, and integration into our clinical assessments. Artificial intelligence is the science and engineering of making machines intelligent. And machine learning, by association, is programming these machines with algorithms such that the more they acquire data and the more they require, say, ultrasound images, the better they are, the more accurate they are, the more intelligent they are. So you probably realize the face recognition on your phone, that's artificial intelligence. 3 examples of this technology with ultrasound are a company that makes a probe that if you put on the lower abdomen, it can locate the bladder and tell you the volume of urine. Perhaps you want to assess cardiac function. You can put the probe left of sternum. The machine and the image on the screen will tell you whether to rotate, slide, tip to get a perfect parasternal long view, determine the ejection fraction for you. Finally, if a patient presents with undifferentiated dyspnea, one company makes a machine where if you do your lung ultrasound examination, it can count the B lines for you and tell you whether or not this is suggestive of acute interstitial syndrome, which we know is commonly decompensated heart failure. I'm convinced that artificial intelligence is going to make ultrasound even more ubiquitous. It's going to help those of you that fall into the category of late majority or laggards. It might even help the phantom scanners. So maybe some of you have never used ultrasound. My parents, they had never induced vomiting in any of their children, and they're not medical. So they had me get over the kitchen sink on all 4s, sort of tabletop position for those of you that do yoga. And every single time my father went to put his finger in my mouth and I gagged, he would lose his nerve and he'd remove the finger. And this went back and forth. They'd made me drink orange juice because they knew I hated orange juice, and thank goodness there was no ipecac in the house. Ultimately, they gave up. I didn't vomit, I didn't die, and I still do not drink orange juice. 3 chapters from my childhood: abdominal trauma, measles, aspirin overdose. Things I've learned about ultrasound, about teaching ultrasound, and what ultrasound can teach us. No more phantom scans. If you don't record it, it didn't happen. Nobody can force you to learn ultrasound and become competent in it. Vaccinate yourself. Learn ultrasound. Artificial intelligence technology with ultrasound has arrived. Let it be your coach with you at the bedside each time and every time. It's not going to poison your intelligence. Thank you very much.